Okay, I think we're ready to get started. Thanks everybody for joining us. We're so excited to have our esteemed panelists here with us. My name is Jen Robinson and I will be moderating today. But first, want to introduce the individuals who are going to be walking us through this really important topic for benefit consultants, benefits leaders, plan sponsors, people who are obviously very laser focused on the cost that they're seeing right now in pharmacy. So to start things off, I'm going to introduce you first to Jason Perot. Jason is Senior Vice President at Vita Health and has been since June of 2021. His focus is on innovation, growth, partnerships for that health technology company. Previous to that, Jason led the healthcare and well-being strategy of the Boeing company since 2012. And then, Boeing is the world's largest aerospace company and top US exporter. And before that, Jason joined AT&T, the world's largest telecom company in 1994. He was a chairman of the board for Midwest Business Group on Health, and a board member for the Employer Health Innovation Roundtable, the Integrated Benefits Institute, and Pharmacy Benefit Management Institute. Obviously has a lot of experience with these large organizations, and glad to have him joining today. We also have Lee Lewis, who is the Chief Strategy Officer at the Health Transformation Alliance. Lee has advised healthcare strategy at Fortune 10 employers, insurance companies and administrators, medical associations, and the Departments of Justice and Labor. He incubated and helped form 24 health benefit startup companies. Lee was a founding member of the Health Rosetta organization, the co-founder of the Health Value Exchange, and previously a consultant. And his work at the HTA is extraordinary in bringing together this large group of employers who really want to be focusing on providing value, great experiences for a member, great value for the employer. We're really thrilled to have Lee and his voice joining us today. And then finally, to round this out, we've got Kimball Thomas. He is a veteran founder and CEO who built and sold pooltables.com, and then some Brazil-based e-com retailers, baby.com and Dinda.com. I think I'm saying that right, Kimball. He has drawn on his consumer experience to bring a new level of member experience to the employer benefit space with Walrus Health, which is a digital platform for individualized medication management. So really happy to have these folks on with us. I think the attendees are going to gain a lot of insight and value out of what they have to say. So with that, let's kick it off into our discussion. So first, I want to orient you to a slide and to some data that you likely have seen. This is Business Group on Health data from their 2025 Employer Healthcare Strategy Survey. And this is looking specifically at employer RX spend percentage of total healthcare costs. And we're seeing that increase pretty rapidly here. 2021, we were at 21%, 2022, we were at 24%. And now, this last year, 2023, we're at 27%. Obviously, if this bears out, we are looking at 30% for 2024 and beyond. So my first question, I'm going to shoot it over to both you, Jason and Lee, to be, considering how we can help our attendees today. First off, how did we get here? What are some of the key events that have driven these rates of increase?
Yeah, thanks so much, Jen. And it's a privilege to be here with a great panel of colleagues in the industry. So I really want to just thank you for the opportunity and thank you for the attendees on this webinar. I would just give a couple quick observations as we think over the past decade, just to kind of frame that up. We've seen an escalating trajectory on cost attributed to specialty medications. When you think about where is all the R&D dollars flowing in from, research and development with pharma and biotech firms, largely it's all flowing towards specialty medications, which typically cost a lot more than what we've seen over the decades with, generic medications. And because of that, that's one key. I would say there's a lot of other opportunities when we think about some of the constructs within the PBM contracts that employers have been grappling with, relative opaque nature of it. And with that, creates a lot of opportunity to unlock value and more transparency as well. But over time, we've definitely observed like a escalating cost healthcare trend and on spend related to medical and pharmacy for that matter. And that just creates a ready now opportunity for employers and consultants alike to, think of ways to pull on levers to tamp down, escalating cost trajectory.
Yeah, sort of laying into that, and also terrific to be here with all of you. Thanks for tuning in. Uh, I was just looking at the data, at least across our membership, of a little over. The report I was looking at is employers that we had aggregated with one of the big three. It was a little over 1 million lives, and when we look closer at this data, it's like, okay, these are skyrocketing, but our utilization is down about 1%. So the number of pills that we're actually consuming has actually gone down by a point. We looked at our generic utilization. That's remained mostly the same. We're up in the mid 80s to low 90s in terms of generics, and the unit costing hasn't shifted much. Brands only went up about 2 points for us in terms of the unit costing. Uh, Really, where it's hammering everybody is the increasing consumption of drugs that have much higher unit cost, and that may be natural for everybody, but it does help us to isolate the problem. It's not like we're having a problem with 10,000 drugs and it's like overwhelming. No, 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 no. We got no problems with generics. We don't have a problem of people getting sicker. We don't have a problem of us suddenly like consuming way more medication. None of that is the issue. It's just unit cost on what we're taking. It's GLP-1s, gene therapies, and all the new R&D going into specialty. So if we can tackle the unit costs on 2% of our spend, that can help us to draw down and reduce and mitigate the trend uh, within this category.
Very helpful. And, that leads us nicely into our next discussion, which is around the traditional guardrails that we've had here to help tackle some of those potential increases in spend. So, my next question to you is, what are those guardrails that we have to help prevent the waste, and to help with this cost avoidance? And then my follow-up is, are those guardrails working?
Yeah, so in regards to guardrails, Jen, I would, maybe suggest a few different swim lanes or channels when we think about how we manage pharmacy cost and avoidance and savings and spend altogether. When we think about the contract itself, as a plan sponsor or an employer, what do you have the control and command and the power to do within the confines of your PBM contract in terms of having maybe flexibility to customize your formulary? So that's another channel beyond contract management. Do you have the right to customize your formulary and really have, I would say, an active role from a formulary management standpoint? So in the aim of hypothetically thinking about trying to structure a waste-free formulary or aspirationally trying to achieve a waste-free formulary where you can, have the right to carve out and exclude medications that might be egregiously excessively priced. Do you even have the opportunity to focus on that or not? Are you relegated to whatever the, standard preferred formulary is from the PBM? What relative to network, retail, pharmacy, network management, do you have the right to even direct contract with, retail pharmacies, or are you basically trusting that your PBM is taking care of all that? But probably the biggest one beyond those that I mentioned, also that's been in place for many years, is utilization management, and that could include prior authorization criteria, some of which might have an opportunity to be made more stringent and more effective. And there's ways to certainly mechanize that if you have the right in your contract to customize your prior auth criteria, quantity limits, clinical step therapy edit rules. I mean, there's a range of utilization management levers that you could leverage in order to try to mitigate the waste that typically flows through. So when we think about pharmacy cost avoidance or cost savings derived from all these different levers from a management standpoint, whether it's contract, formulary, network, network, utilization, et cetera. Those are a number of ways that, they can certainly help out. On the PBM side, I would also quickly say that largely the PBMs, they've been around for decades and, they're really good at adjudicating claims. They're really good at dispensing medications from a mail order basis. But, there's definitely ample opportunity for other third party vendors in the market to step up and fill in gaps and do better and raise the bar on efficacy and medication adherence and other things like that. So we've seen a range of solutions over the years step up to, arguably provide a better value prop in the aim for RX cost avoidance and savings.
Mm-hmm. Helpful. Thanks. How about you, Lee? What do you have for us?
Yeah, so you can steal this from me, but just gossip nice about me if you're using it. But the four major steps that we just use when we get our companies, we say, look, we're dealing with this problem. It's clear, steer, severe, and adhere. Those are the four major levers that we look into. Clear being make sure that you've got a great contract, ideally a clear pass-through, transparent contract. Even if you're using a big three PBM, which have historically been against this, you can still get these terms inside of a big three contract if you carry it out in the right way. I know there's many of you on the call who are pharmacy consultants. It's probably what you do day in and day out. Second thing is steer. It's get control of your formulary. Our groups who perform best, all to a employer. These are all, Fortune 100, Fortune 200 in some cases. Every one of them has said, look, I'm going to take formulary controls away from the PBM and I'm going to give that to an independent P&T. They can hire a consultant to do that, whatever it might be, but you should have somebody independently managing the formulary to lowest net unit cost. You are going to give up some in rebates, but it tends to pay off 4-to-1. The third is severe. That's getting into your specialty drugs. Our top performing groups have a separate clinical team that just manages the specialty drugs, and they pull them off the conveyor belt of kind of the standard pass-through transactional medicine. By managing those drugs separately, they can ensure that each one of them is being prescribed for a given indication, that it's not going off label, that we're getting the right titration, the right amount, and that it's not contradicting with other areas. And ideally, that we can step therapy in a logical way. The final is adhere. This is the hardest because it deals with regular human behavior. About half of your people are taking medication in any given month. About a third of your entire population are on some type of chronic medication. And when individuals stop taking these meds for whatever reason, they immediately put themselves at higher risk to having more costs and cost spillover in other areas of the organization. And that spillover cost is an indirect cost of pharmacy management. And it could be that it's too unaffordable or the coupons ran out or maybe somebody's just too busy. But whatever the reason is, if nobody's looking after your patients to make sure they're staying adherent to their medications, you run into huge problems. The other piece within adherence is what happens if we are being adherent to our meds, but we're taking two meds that cancel each other out or worse. That happens all the time. No PBM is in touch enough to be able to catch all of that. And no doctor is omniscient in order to avoid prescribing something that could be against what some other doctor has prescribed years ago, and there's no way to check. So having a clinical team that simply runs a search across all your drug spend, sees all the patients, who's taken what, and make sure that there's not contraindications, or if somebody very clearly needs to be on a medication and they fall off it, that there's somebody there to hold their hand and bring them back and put them back on the safety shelf. And if you can pull those levers, though, and there's efficient ways to do each of them, you may not do them all at the same time. We've seen that flattens drug trend, even in today's environment.
Yeah, that's really interesting. Yes, I did write all of those down. They are very interesting. I'm especially interested in that last one and the notion of a clinical team who is laser focused on watching the puzzle of medication, especially for a person who is dealing with one or more chronic conditions and who is likely taking medications in the number of, 4+ medications and the complications that come with that. And I imagine that can be difficult for certain organizations to have dedicated clinical teams to be watching that, right? And this is where I think a lot of guardrails maybe are intended to assist, but we do see a lot of things slipping through the cracks. So I want to turn to you next, Kimball, to walk us through what that actually does look like when we consider, someone who is well managed, because I think in many ways, Lee, you are defining a bit of what well managed medication can look like. And so I want to contrast that, Kimball, with what does poorly managed medication versus well managed medication look like for an organization across an individual?
Yeah, thanks, Jen. And great comments from Jason and Lee. Lee, particularly poetic. I think that there's a number of things that have kind of come up, in my view, on this topic. And Lee mentioned earlier, this issue of prescribing and, average unit cost going up, and that being one of the key drivers. And you can kind of, map people by number of chronic conditions and total cost. And it's interesting how you can see these different cases pop up because drugs are very powerful. Number one, activity in the benefit, and the number one reach for people who are managing chronic conditions. And when the drugs work, they're taken as intended. These drugs can do an amazing job at managing a condition in someone's life, both in terms of how they feel and how the condition manifests itself, but also, as we're looking on this slide, in terms of cost. And similarly, you can really see when things are not working. And this is where you get into people who have medication-related issues. They're not getting the full value out of the drug. They're likely not on the right drug, or as Lee mentioned, not taking the right drug. And so when we look at people who have medication-related issues as compared to people who do not have medication-related issues, you see this dramatic uptake. So on the left side of the bar chart there, you see that well-managed, and there's a very logical stepwise relationship there. As people have more conditions, the cost does go up, and this is total cost of care annually. When you see people who have medication-related issues, there's a huge spike. And we see typically 3 to 6 times total cost of care, total plan resources being expended on people who have these poorly managed medications. And this is a very interesting opportunity because, as outlined, we have a lot of guardrails in place, a lot of plan level, admin level things that can be managed, like the things that both Jason and Lee have outlined. But these are cases that are still getting through. These are people who are on drugs that were prescribed, came through plan resources, and yet they're just not getting the right results. And so this is where we really look to focus.
Thanks, Kimball. So for people who we know that there are many different drugs available to people to help them feel better, but just because a person receives authorization to take a drug doesn't necessarily mean that that particular drug is going to be the right fit for that person. And it's often something that we see that does impact that previous slide. This is how we get to that dreaded RX waste. So for people who are taking multiple medications, feeling good on your meds is about so much more than just taking the med that is approved. When people take drugs that are hard to tolerate, they may not take them as directed, which makes them less effective. When people are skipping their medications because they can't afford them, we know that that has been a very real issue over the last few years. There are people who are choosing between, needing to pay for rent or groceries or pay for their incredibly expensive medications. We're seeing that. Obviously, they're not going to see a benefit, and it's going to have some really serious downstream effects. And then some people, are even taking medications together that can cause a cascade of further needed medications. We see this as this cascade of side effect treatments. And yes, prior auth is supposed to catch a lot of these things, but I'm guessing there's at least one employer on this call or, a pharmacy consultant who's seeing this where people are still managing to fill, say, a GLP-1 prescription for obesity, even though it should have been flagged by prior auth as not covered. So, I want to turn back now to Jason and Lee because we are talking about this discussion of active medication management. And I want you to, something I've heard you speak about before, this might be a new concept for our audience. What do you see as the difference between traditional drug utilization management and now active medication management?
Yeah, Jen. So when we think about just real life, and I think many people on this, call and webinar can relate from their own personal experiences. What happens? You might pick up a medication or multiple medications at a retail pharmacy in your local community, or maybe some of that, if it's maintenance meds on a 90-day fill, maybe you're taking advantage of mail order and it's shipped to your home. But either way, what is the frequency? What's the interval of actually having dialogue with someone from a clinical or pharmacist standpoint, right? Very few of us really have established a relationship with the pharmacist in general where they have the time and they're not busy just filling scripts and moving on to the next patient. So in order to, think about, this range of opportunity around active medication management, arguably this has been a big gap when we think about we're spending a lot of money on all these well-intended, prescription medications. And are we able to tolerate it? Are we able to adhere to it? Are we able to afford it? And over time, especially if you're in a polychronic state, grappling with maybe multiple chronic health conditions and comorbidities, you could easily be on north of 10 to 15 different medications and over-the-counter medications when you think about people in a complex patient state, how all that gets pulled together and is made easy and simple to adhere to and follow and raise questions with. It's current state is just not very easy for most patients to do that when you think about all the different factors that go into it. So when we think about how active medication management what it can do for an organization, what can it do for a patient, I've always focused on how can we raise the bar around the member patient experience in any strategy, healthcare well-being, pharmacy strategy. How can we focus on raising the bar to take the complex and make it simple for the patient and make it accessible and easy for them to utilize and adhere to. And then when we think about the savings that's derived from that, that's really over time where we are able to quantify the clinical effectiveness or success metrics and clinical outcomes that prevail for our patients, right? Because they're staying adherent, they know what to do. If they have any side effects, they know, what the fallback options might be. And on top of it, there might be, less costly therapeutic equivalents and medications that they could utilize to save a few bucks on top of it as well, which could really help them out as well when we think about the disparities in healthcare utilization. So all that being said, that really presents the question, how active medication management could really raise the bar on all these different aspects that, patients, whether they're getting a 30-day fill or they have multiple fills on different refill dates, how they can sync that up and stay on track and certainly afford it and achieve the outcomes that they're hoping to live a better quality of life can certainly do. And that's really where I think this comes into the picture is we have a real need, we have a real opportunity, and this is the pathway to bring it all home.
Thanks, Jason.
So everybody on the call, think of like, if you're a consultant, think of the most challenging employer you can to engage. And if you work in benefits, think of the different employers that you've had or different segments of your population. Think of the hardest one, the hardest segment of your population to engage. We had an interesting example of this come up a couple of years ago. One of our groups works in industrial sorting facilities, okay, which are always located in like the least desirable area of town. They're big industrial setups. Nobody can bring a cell phone inside. Most of the employees inside, because it's just very simple sorting tasks, the wages are very entry level. And inside the facilities, they speak about 30 different languages. Not equally, right? I mean, there's mostly Spanish and then Farsi, and then it sort of starts to scale down from there. But lots of different languages. Many people don't really read anything, and certainly not in English or Spanish as kind of a first language, and so it's extremely hard to communicate with them. But we needed to save money, and we thought that this could be a way of doing it. Uh, there wasn't anything to lose because the contract was good. We were only going to pay if we used it, and uh, we had a good guarantee on the ROI of anybody who did use it. So it was totally de-risked for us, and we thought we'd give it a try. Our assumptions going into this, both mine and the benefits team, as we began the program, was one, assumption one is none of the people in the sorting facilities are going to really use this. Like there might be, if we think maybe some people in HR executives would use it, but we don't think that the individuals out there would. Second, if they did use it, we didn't think they'd really like love using it. We thought that they might just kind of get coaxed into using it because we caught somebody at a good time right after hours on a phone call, right? But nobody wants to be, engaging on their health. That was kind of our thought, and certainly not on their medications. Like, who cares about that? And then the third assumption I had is that even if they even if they did use it and they liked it, that it wouldn't necessarily turn into uh, something that was really high engagement or that would, spill over to help a lot of other areas. Our thought was, okay, let's give this a try. It'll probably be the executives. And then 6 months into it, I ended up being wrong on everything. So the first thing is we didn't think anybody would use it. I was totally wrong. A lot of people used it. We had over a fifth of all the people that were reached out to or that had the opportunity to be engaged on this ended up actually using the solution. And it wasn't even just like a one and done, like, maybe I took the phone call politely, but I just got off quickly and that was that. But these individuals were like reoccurring. They were coming back to their pharmacist and asking lots of questions and engaging in a lot more. That was shocking to me. So we had really good engagement. The second thing is the thought that they wouldn't use it with enthusiasm. I was totally wrong on that as well. People seemed really engaged in this. It was so much so that we started getting requests of people wanting their family members or friends to be able to use the service that weren't, in some cases, weren't even on the health plan. And I'm like, we've never had this problem before. Like, we can't get anyone, if we're paying someone to use a program, we basically can't make them use it. Or if they do, it's begrudging. But for someone to be referring it to a friend at a barbecue, we'd never had that problem before. And suddenly, this was a totally new experience for me, is that people really did enjoy having somebody to talk to about medications. They had questions and nobody was giving them answers. And suddenly they had this really expert outlet of a real human that they could engage with in a really convenient way. And that was a shock to me. That was a shock. And then finally, we thought only the executives would use it. And in the sorting facilities, the industrial plants, we weren't going to get any utilization. When the data came back, I was floored. The highest utilizing group were the utilizers inside the industrial facilities. It was not the executives. It was people who were taking a lot of medications, were freaked out about what they were putting in their bodies. They had tons of questions. They had nowhere else to go. And they'd kind of been overlooked by society. Many of them were in a little bit of care deserts. They might have 8 or 9 roommates. I mean, they were in more compromised situations and they just didn't have access to any type of expert. And they were the most likely to come back multiple times and engage a lot with their pharmacist to ask questions about different things. And so that completely changed the way I think about medication management. It turns out every American has real questions about all the chemicals we're taking. Uh, I don't know if that was accelerated through all the misinformation, everything that came out during COVID, or, the big national debate on, what's appropriate in terms of vaccines or whatever it might be. But people have a ton of questions. GLP-1s are out there. You've got Oprah telling people they need to take these new meds. People have a lot of questions. They are looking for answers. They're looking for expertise. You can't get it on Sports Center. They're trying to reach out to new avenues, and it has completely changed the way that I think about this particular category. I think this might be one of the most overlooked opportunities in healthcare.
Really helpful context. I love how you're illustrating it in such a practical way. And what I am hearing from you is, yes, on one hand, we're seeing such a benefit. Organizations that implement this see such a benefit on their numbers, right? But it's the member who's suddenly having a true experience that they have not seen maybe ever, maybe for a long time, depending on what kind of local pharmacist they had. And, it's really making an impact. Thanks for all of that information, incredibly helpful. And I anticipate that our audience is seeing some value here too. And I want to remind the audience, we would love to answer your questions. I'd love to answer them as we go. We've got a couple coming in, so please send your questions through. I'm hopeful that we'll be able to get to as many as possible during our remaining time that we have here. Okay, so great discussion around how we should be thinking about this. This might be a potential reframe here. So I want to show what this looks like in practice. So when we're looking at active medication management for the individual level, we're looking at a lot of, really a lot of what you laid out, Lee, is the example of what this is. This is continuous member level support, right? These are people who are able to go in on their breaks, after hours, before or after work. They don't have to worry about needing to take time off. They don't even need to worry about scheduling an appointment. These are people who can go get that care at a time that's most meaningful for them, and longitudinal care to answer the questions around their medications, what's working, what's not, and maybe finding gaps or finding side effects that are really problematic. These clinical pharmacists are obviously at the core of this. We are going to be talking about clinical pharmacists in just a minute, so hang tight on that one. But forming that type of relationship is really the fulcrum of what allows that continuous level support to succeed. And then on the flip side, not only does the member feel really great support, but they're also bringing in insights that you just don't see from an eligibility file. You just don't see it from your claims that come in every day or every week or every 2 weeks. These are insights that they can surface within an app. They can be talking to their pharmacist about it. And those insights can have really significant impact on the way that the person is feeling and on how their medications should be handled. And then obviously we can leverage technology in order to make those improvements even better. And then finally, we are indeed seeing pharmacists, these clinical pharmacists, filling in gaps with these care teams. The reality is people just don't spend time with their PCP or with their specialist the way that they used to. I don't know about any of you, but for me, I actually literally just had a visit yesterday. It's 6 minutes in and out with my provider. And you know what? She's actually a good provider, but just the way it is now. And I found myself immediately texting my Walrus pharmacist about the things that I discussed with my provider. And that's the kind of power and value that you bring when you add an additional body to that clinical care team for these people. So let's move forward and let's actually talk specifically about clinical pharmacists. So Jason, Lee, what role should clinical pharmacists be playing as we're treating populations?
Yeah, so when we think about just again the current state of, I would say consolidation and closures of retail pharmacies, we're seeing a lot of disparities when we think about zip codes and where people live and work. What do they have access to, even from a retail pharmacy standpoint, let alone a pharmacist that has the time at that brick and mortar location and truly spend time with them. So, I really believe that when we think about the role clinical pharmacists can play in treating populations, it really wraps all that we just covered just a few minutes ago all together for the good of that patient, one patient at a time. And we see, I would say, based on my past years on the employer side, it was pretty typical. I would see about 10% of the overall workforce that had zero medical and pharmacy claims. So that's great. They're not utilizing healthcare. They're healthy. Maybe they're younger, but we clearly saw a slope go higher and higher, by which the older you get, you tend to find more chronic conditions, maybe cancer, maybe other disease states that creep in as we all age. And, we tend to see a higher proportion of medications that are being utilized by our patients. And with all that, it becomes from simple to very complex. Certainly when you're in a polychronic state, maybe grappling with type 2 diabetes, hypertension, maybe COPD or CHF on top of other, maybe underlying mental health, anxiety, depression. When we think about SSRIs and SNRIs that might be prescribed to, try to offset the anxiety, depression that's going on. And that could be just a range of trial and error with all those different medications as far as what can you tolerate and what's really effective clinically. And I think that's really the core of this is like when we have access, like you just described, Jen, to a clinical pharmacist that can really make heads or tails and common sense on, are you on the right medications? Are they working well for you? Do we need to revisit anything? Is there potential cost savings with, perhaps generic alternatives or therapeutic equivalents? It might be pennies on a dollar based on whatever is being prescribed. I mean, there's a range of good that can really come together. And then from a population health standpoint, where I tended to look at things in the aggregate level, just like Lee probably does from a HTA perspective, you really have some rich data sets by which you can identify different cohorts and slices of your workforce that might be utilizing clinical pharmacists versus those that might not. And from there, it can be very interesting to see what type of differences in terms of all the things that matter from a, success metric standpoint are quantifiable and really prove the difference in, the overall medication adherence and improvement in outcomes, and certainly the cost savings that come with that too. Again, not everyone needs a medication, right? Maybe there's other good, healthy, diet, nutrition, and other resilience and sleep health management things that could be leveraged as well. But that might not be the answer today. Maybe that's the longer term goal for the patient. But the clinical pharmacist can really bring everything together when we're thinking about one patient at a time and one population at a time as well.
Thanks, Jason. Do you have anything to add there, Lee?
We need somebody to review our pharmacy consumption. People are getting prescribed, especially your big polychronic spenders, where you've got hundreds of thousands a year going out in cost. You have different specialists who are prescribing medications to everybody, and there's no adult supervision to make sure that there's not a toxic cocktail. When my grandfather died, we went through his cabinet. He was taking 11 meds every day. We found one blood thickener and a blood thinner that he was supposed to take every day. And it was that sort of thing. Not only is that not surprising that that could occur, but those types of mix-ups happen all the time. And it's really a miracle to the robust human spirit of our bodies that we're not all running into more problems uh, as as we become more and more complex in our medical needs as conditions accumulate or as we age. And having a pharmacist there to restore any missing medications that we should be taking and have fallen off the wagon, or maybe they haven't been given in the first place, to replace any that we're taking now that we really should be taking something else, remove medications that are not doing us any good, and to reconcile whenever we have contradictions or contraindications in the medications. That service is not performed by anybody today at all. And I've now seen that if you add that to your population, you're going to save a lot of money, and people value it a lot as well. And so when I meet with, I'm not a consultant, but when I meet with my groups or we're talking about different concepts, this is one of the first things that I mention. I'm like, there's no reason not to have this there. If nobody needs it, you pay nothing. If people do need it, they use it and they love it, and you save money and possibly save a life. This is a really, really easy strategy.
The other thing, I love hearing the different perspectives. And the thing that keeps coming back to my mind is, let's say someone were to have this kind of person at their local retailer or pharmacy. It could be a big box pharmacy or not. The reality is we're seeing, and we know this because we're seeing many of these big box pharmacy retailers closing locations, to the tune now that 50% of the US is now in what is designated as a pharmacy desert, which means there is a pharmacy, but it's more than 10 miles away from you. That is prohibitive for many people in the United States. And we're going to see this more deeply impact. We know that a lot of these populations tend to have higher rates of chronic disease and higher drug utilization. And the odds of what you're talking about here, Lee, of where there can be medication crossovers, maybe they're going to one location to fill and another location to grab a different one, we're going to start seeing a lot of problems. And so having somebody who's dedicated to ensuring that a person is getting the kind of care that they needed with pharmacy is going to be really critical here in this next stage of healthcare here in the United States. So we are quickly running short on time. So I'm going to move pretty quickly here through these next few slides that I have. I want to talk really briefly about what this looks like, what this kind of longitudinal care can look like for a member, and how a pharmacist can indeed have such a meaningful impact. I mean, it really comes down to the member experience. So you can see here in this first view, we have people are strategically reminded to engage with their pharmacist. They can provide important clinical information to the pharmacist. This is done in conjunction with claims data that is fed through as well on the back end. And then they have async communication. And as I referenced earlier, this is where we can surface a lot of these bigger issues that we may not catch in some of these other places. And then they are encouraged to check in daily with their symptoms. And it's so compelling how a symptom can be indicative of a problem with a medication, right? And when you have someone who's checking it daily, we catch these things much faster, and we eliminate some of that potential cost waste that we can see. This resolves medication frustrations, reduces costs, it improves a person's quality of life. And then this is the pharmacist dashboard that they see on the back end. And Kimball, we might need to kind of fly through this a little bit. We're having such a good, robust discussion. I love it. But if you just want to show us, really quickly, with the amount of data that we have available for a member, it's a lot of data. We do want to use it in multiple ways. We want to segment the populations who are going to most benefit from this active medication management, people who are going to bring the highest engagement and the most cost reduction. We also want to be optimizing the care. So if you just want to quickly walk us through these three panels that we see here to illustrate what type of action is available when you do intake all of that critical information.
Yeah, thanks, Jen. So this is what a pharmacist sees at Walrus. And this is part of how we create very compelling member experiences, because on that left panel, and you can't see because you can scroll down and you can see those conditions there. You can click on those and they expand, but we have all of the data around this person. So when there's an interaction, we don't have to do a lot of the typical types of questions around what's your situation, what's going on. We know every drug they're on, we know all their diagnoses, and we can really kind of get to the heart of the matter. And part of the Walrus worldview is that there's a very important data feed that we also need to have, and that is the member experience. This is engaging people about the drug itself. As Jen mentioned earlier, they've proven their candidacy for the drug, they've got the prescription, it's getting filled, but is the drug right for the person? And so on the right-hand side there, you can see the member data feed. And this is where people share messages. You can also see their symptoms and their polls. Anytime somebody touches their thumb in the Walrus app, the pharmacist can see what they're doing. And by getting that feedback from the member, we're able to bring the claims data and all known medical information about somebody with the member experience data and mash that up. And in the center panel there, you see opportunities. And this is where our software helps our clinicians work quickly to be identifying very clear areas that we can see. And so that's the pharmacist view.
Thanks, Kimball. So I now want to give a quick overview of what this looks like for a member specifically. So when we have a member here at Walrus, this is pretty illustrative of what a typical member at Walrus experiences. This individual is a 55-year-old female, has type 2 diabetes and hypertension, and current drugs include multiple diabetes medications. And, she's been working with a Walrus pharmacist for about a year now, and in that time has seen some really strong improvements. Her medication satisfaction has gone from a 3 to a 5. That's a great improvement. That means she's feeling better on her meds. She's feeling better about her meds. And in addition to that, we're seeing a real clinical outcome here too, which is that her A1C has dropped from 7.4 to 6.0. By all accounts, this is a person who is experiencing the very premise of what active medication management can do. However, as a part of her routine care, because remember, we saw that a person can check in often, they can share things that are happening in their lives. This person does report a hypoglycemic episode during one of those check-ins, and that was flagged. As we saw in the previous dashboard, the pharmacist saw, okay, we've got something going on here that should not be happening based on the medications this person is taking. So, as a part of this routine care, the pharmacist notes it. And immediately follows up to see if she can help this member feel better. So, as a process of looking at that, the pharmacist reviews the medications and the profile and counsels the member on how to manage the hypoglycemia, and then suggests, you know what, actually, we probably need to deprescribe one of these diabetes medications that you're on. This is a common side effect. And then recommends, you know what, titrate up a different medication to ensure you're still seeing the correct benefit, but we can maybe eliminate one of these side effects. The members start seeing improvements in glucose, not seeing the same type of issues. And the pharmacist and member, this is an ongoing story. The story is not completed. This is a member and a pharmacist who are having regular communication. And in addition, the pharmacist is also having regular communication with the member's physician. And so they're able to have this really great feedback loop of, again, I always refer to it as this puzzle of medication and how to manage the right medications for how a person is feeling. So we know that for members with multiple chronic conditions, their medications and care plan need to continue to be evaluated. So moving forward, I want to touch very briefly on an important thing here, because the only way for all of this to be happening is if people engage. Just quickly hear from you, Jason, Lee. What are some best practices that people on the call need to be looking for when they're evaluating what impactful engagement is going to be?
Yeah, just real quick. We know today we have a very disparate, siloed, fragmented healthcare system by which we're seeing maybe direct-to-consumer solutions, maybe B2B solutions, point-based solutions, and our brick and mortar, primary care docs and, maybe OBGYNs and other specialists and, various clinical categories. So we really need to bring it all together. And I think on impactful engagement, what that looks like to me is we're addressing the appropriate audience that has a need and can benefit from this, right? So when we think about those that are the big fish in a pond in terms of ROI, return on investment, it's going to clearly be those in a polychronic state that might have those 11 medications that they're taking on a daily basis and bringing that all together. But it's going to vary, quite a lot from one employer to another. But I think when we can ingest medical and pharmacy claims data, that will be very insightful to really extrapolate in the data how we can best target that cohort of people that can benefit from the engagement with, something that's impactful like this.
Thanks, Jason.
Yeah, I would just say that any engagement is good engagement. If you can get people to engage with an expert or a clinical provider who they trust, that will generate good results.
Appreciate that. Thanks. You both talk about how any engagement is good and it needs to be the right person, right? The people who are going to benefit most from this. And Kimball, we've got a few slides here that I think illustrate this really nicely. So I'm going to toss this over to you for a moment to walk us through this overview of what that segmentation conversation does look like in a population and at an individual.
Yeah, so when we think about the people that we can really help, the initial focus is on a group like what we're seeing here. So based on a population of 10,000, you're going to see around 15% fall into this group. And like that chart we looked at earlier, these are people who you can kind of see from a long ways away are really struggling. And you can kind of see what the different attributes of these folks are. But as you move through, you can see that their total cost of care is about 4x everyone else. They are on 4 times the medications. They go to the hospital 4 times as much. And so this presents a very clear picture of people that we can help who we're going to target initially. So if we kind of advance here and we just look at the individual, we're going to look at how Walrus views the opportunity for savings. Here you can see we have a monthly engagement fee of $68. And as we've talked about this is really more of a continuous care model. It's about matching the consumption of drugs with the guidance and the feedback loop for those drugs. And we see high levels of ongoing engagement. And here we're showing 8 months average, 8 out of 12 months. And that would make a fee of a little over $500 per active user. And that obligates us contractually in our 2-to-1 ROI guarantee to reduce drug spend by twice that amount. But in our experience, we actually do a little bit better than that. So we're going to be obligated to reduce drug spend by $1,000, typically going to see $1,400 per active user in drug savings. If we zoom out to the population level, looking back at that 1,500 or at that 10,000 life group again, this is what we would expect to see for a population that size. In terms of fees, where we're seeing about 160,000, guaranteeing 320,000 in drug spend reduction, but probably seeing more than $400,000 in drug spend reduction. And in addition to that, there's a lot of medical savings, as we've been touching on. People feel better, they're doing better, and those medical savings are something that we also report on. And I think that, just kind of bringing that all together, I think that, Lee shared that kind of poignant personal anecdote about his grandfather earlier, and it reminded me of a consultant I spoke with recently, very enthusiastic about Walrus and this approach. And I said, what's your touch point on this? I was expecting a personal story, which is common. And he said, I had this kind of, college job, as we have these kind of, crazy college jobs. And he would actually clean out an apartment after somebody passed. And so he was cleaning out a lot of apartments, and he was removing things after they'd passed away. And he said, there was always garbage bags full of drugs. And as a young person, that always just really felt off to me. And I don't regularly see people talking about waste that's getting through the system. And as soon as I was hearing about this, I went right back to those experiences. And I thought, God, that is interesting. And it's consistent with what we see, as Lee shared, where drugs are, going past each other. People are on multiple of the same thing. They're not getting the result that they could be getting if they were simply aware. And so there's a big opportunity here, and Walrus helps to capture it.
Thanks so much. Time flies here, and we are short at the end of our time. So I'm going to kick it over one last time to our esteemed panel here with Jason and Lee. What final words of wisdom do you have for the people who've attended, who are dealing with these issues, who are trying to put things in place for 2025, 2026? What words of wisdom do you have to share here for them?
Yeah, just real quick. Thanks again, Jen and Kimball, for the opportunity. I would tell you that I was at a recent meeting with over 20 employers, large jumbos, mid-market, and the question was raised, what's your healthcare trend and spend for 2025? And I would give you a ballpark average. It generally ranged from 8 to 12% for the majority. One was as high as 23%, one was as low as 6%. And a lot of this was really an opportunity for all of them to step back and reflect, how can we pull levers to focus on cost avoidance and cost savings when it comes to medical and pharmacy, which account for 70 to 80% of the overall healthcare budgets and spend that they incur every year amongst everything that they're doing across the whole spectrum. So when we think about the escalating costs and trajectory on pharmacy spend and medication spend, we know every year in January, July, you see increases on drug price inflation from pharma. We see that, flow through with the payers, and, the employers are the fiduciary. They have the opportunity to take control of what they expect out of their spend. They're making an investment, and, they have a real opportunity today to really rein it in and really tamp down that escalating costs trend on healthcare spend for 2025.
Bring us home, Lee.
Honestly, you can't go wrong. Just do something in this area. Look for a solution. Walrus is right there and it works, but whatever it is, you really should implement something to help out, to help overlay what's going on with drugs and medication. It's a place where you can get easy advantage in savings and also be able to have significant measurable impact on your health outcomes.
Thank you so much. Well, with that, we're going to close out this hour. Thank everyone for spending their time with us. Want to thank again Jason Parrott and Lee Lewis and Kimball Thomas for their time and the great insight that they bring from their wealth of experience and the innovative things that they're seeing. I know I have learned, and I hope each of you has something to take away from today. We will see you on the other side. So thanks, everybody. Enjoy the rest of your day. Bye-bye now.